So we are having our two very renowned doctors today with us. Dr. Basab Mukherjee we are having with us. He is a very renowned doctor and obstetrician and gynecologist. Dr. Mandakini Chopra, internationally certified antenatal postnatal specialist. They both are having with us, and we'll take them through. We'll let them through with this session, this very renowned webinar session. So over to you, Dr. Basab.
Thank you. Thank you, Sonia. Thank you very much. Good afternoon, friends. Good afternoon, people who've logged in. This is a session where we just want to run you through some things which a lot of you do in your pregnancies, but some things which we try to make some clarity and some sense about. These are mainly the diagnostic tests which are done in pregnancy. So we do understand that pregnancy has been going on from time immemorial, and there has been a lot of people can deliver under a tree, and you really don't need any special care for most of the people. So around 80 to 85% of women who deliver would be in the low risk. But there is a group of people, 10 to 15%, who need some medical intervention and some hand holding during pregnancy, which will help them to tide over the time when they go through their pregnancy, which is, in many words of many women, some of the best times they have had in their lives. So tests in the pregnancy, I think first thing which we must talk about is need to do, must do, and may do. I think those are something very important things. In a lot of contexts, we bring this up. But in pregnancy also, I think it's important that when your doctor gives you a battery of tests, you may ask yourself this question. It's often difficult to answer, and they'll say, if you did not need to do them, I would not have written them for you. But that's a perspective to do these, which we will be 20 minutes, but some of by the time when we have in pregnancy evaluation, one are the laboratory tests, which would be including blood and urine tests, and the next is imaging, where you have a lot of sonographies done. I think the first section which we will go through in this presentation is the imaging, where we'll be talking about the sonography which we do in pregnancy, why are sonographies done, what happens if sonographies are not done, what do we miss out, and do we need to do sonographies every month, and how many is more harmful for the baby. There was one time when people used to think that sonography is harmful, or too many sonographies where causes rays to go in from externally into the baby and may cause problems, even genetic damage. A lot of thought process was there once upon a time, and all that has changed. And we know that ultrasonography is one of the safest tests which can be performed in a pregnancy setting. So how many to do is always depending upon what type of a setting is as, and it varies from person to person. But what could be defined as routine and what could be defined as extra sonography studies is something which we will go through. So when we talk about routine ultrasonography in pregnancy, usually we talk about these 4 sonographies, which I would line up here, which you can see on the screen. So one is called the dating scan. We will talk, this is not about the Valentine's Day dating. Of course, it's about dating the pregnancy, and we'll come to that in a minute. The chromosomal scan, which is done to rule out or reduce the chance, or to assess the risk of chromosomal problems. And there is an anomaly scan, which is characteristically done to look at structural defects in the baby. And then there is a growth scan. So the sonographies are spread over the pregnancies, and how frequently to do it, when are they done, what is seen in each of these scans, and what can be made out of these is something which we will be discussing in the next 5 to 7 minutes. So the first scan which is done in pregnancy is called the dating scan. So often when women are pregnant, they first don't want to tell everybody. Some people think it's superstitious, because if you announce to everybody too early, then something goes wrong, then you may feel bad at the end of it. So people want to wait till some point of time. Some people want to wait till 3 months. Some people want to wait till the sonography is done, and more or less your doctor has given you a thumbs up that it's okay now, so far so good, and there's a good high chance that this baby is going to go to term and you will carry a healthy baby home. So dating scan is typically done between 6 to 9 weeks. So it's 6 weeks is quite early in some perspectives. Sometimes we do around 6.5 or 7 earliest. But if people come to us or women come to us a little later, 8 weeks and 9 weeks, that also is a time when it can be done. So it is the first scan which is done in pregnancy. The idea is several. The first idea is to check the age of the conceptus. So there is two types of dates which we follow. One is the date which you do follow by the the first day of the last menstrual period, and that is something which helps us to calculate the delivery timing or when the delivery will actually take place. But there's another date which is calculated by the size of the baby's shadow inside the womb. So the baby is like a white streak or a white shadow at this point of time, but assessing the length of the shadow, you can make out in how many millimeters that shadow is, that what is the age of the baby. So most of the times this ultrasound dates match with the how many days the periods have stopped or the last period date. And usually we go by when both of them are more or less correlating, then we will be following the date of when the last period was. But if suppose that there is a big discrepancy between the last period when it was happening and this the baby's size in the womb now, then we usually go by the sonography dates. And that is because it's much more accurate, because some people have irregular cycles, people forget. Sometimes in spotting, you don't count the period, and that is the reason why sometimes the dates can go wrong. The viability of the conceptus is so important to see a heartbeat of the baby. And this heartbeat is usually seen around 6 weeks, 6.5 to 7 weeks, depending on who is doing the scan and depending on the machine which is used for the scan. So generally it is seen at one point of time, and that's called viability of the conceptus. So once you see the fetal heart rate, it's a single or multiple, and this is the scan which also helps it. Other diseases. So when the uterus is small, when the womb is small, at this point of time, you can see the ovary, you can see the uterus very broad disease when the uterus becomes. So this is something which we do as almost a routine from 6 to 9 weeks, and these are the reasons why we do it. So coming from the dating scan to the chromosomal scan. This is typically done between 11 to 14 weeks, and this is the risk of assessing for anomalies. So there are two types of abnormalities which we look for in our women. One is chromosomal anomalies in a woman, in the baby, in the conceptus of our women. So one is chromosomal problems, where so there are hundreds and thousands of chromosomal problems, and there is no way presently in medical science to check for all of them. So what is usually checked is the most common problems which are there, which we know are there, and those are the trisomies, which are called, which is one Down syndrome is one of them. So sometimes a lot of people say it's ultrasound for Down syndrome. It's not just Down syndrome, but Down syndrome is one of the commonest chromosomal anomalies which we know, which is something which cannot be treated, which if a birth baby is born with Down syndrome, he or she has some amount of mental retardation and some amount of difficulty to cope with life issues, which will be there permanently throughout life. So whether a husband and a woman are, whether a couple is willing to bring that sort of a baby into the world is something, a decision which they have to take. But this is a scan which helps us to understand how much the risk is. So the nuchal thickness or the skin behind the nape of the neck is typically measured. And this is something where you can find out how much the thickness is, and that can be put into a formula to find out a risk assessment of what is the risk for chromosomal anomalies. Along with that, there is blood also taken at the same testing. The blood is taken for a few markers, which again are put into the same formula to assess the risk. So this is not a yes and no answer. This is a risk assessment. If the risk is high, then we go to additional tests, like you take the water in which the baby is swimming there, or there's something that's called NIPT. And these are more serious tests in case you need to evaluate further if the first results are high. Then we come to the scan, which a lot of people are very much aware. In a lot of government hospitals, this is the only scan which is done in pregnancy, that is 18 to 20 weeks, which is called an anomaly scan. So 18 to 20 weeks, we see an anomaly scan because at this time the baby is more or less straight, means baby is lying down vertically in the uterus, not vertically always, but it's in a straight line. So after this, what happens? The legs get folded, baby becomes big, and then you may not be able to see the abdomen and all the other structures properly. But at this time, we can see them properly, and so the structural abnormalities can be picked up. It is very important to understand that an anomaly scan done by any person and done by any machine is never 100% accurate. So you cannot say that 100% chance my baby will be okay. That is not possible to say. So because we have limitations of the scan. So 90% of major problems and maybe 70 to 80% of minor problems can usually always be picked up. But you cannot be 100% accurate. And also you understand that there's a background risk of major and minor problems in usually 1% of babies and minor 3 to 5% of babies. But another important thing to understand that what we are assessing here is only the structure, not the function. So you see the brain, whether the brain has developed well, we see the heart, we see the other bone, long bones, we see the spinal cord, you can see the bladder, the stomach bubble. So a lot of things can be seen and a lot of things can be appreciated, but you do not understand the functional assessment, whether this baby will be brilliant in mathematics, whether this baby will grow up to do a wonderful thing in the world, whether he or she will have great contributions. We do not have an idea. There's no functional assessment about how smart or how intelligent or how adapted this baby will be. But at the same time, we have a structural evaluation, and that's all we have at this point of time. The next scan which we talk about in a routine perspective is the growth scan. The growth scan is typically done around 32 to 36 weeks, and this is looking at the growth of the baby. So this is these 4 scans which I'm mentioning are done in a normal baby, normal pregnancy perspective. So if there are abnormalities, like if there is high blood pressure, if there is if there is diabetes detected, or if there are other things, then at the same time we will have to do these scans. Then we would have to do more scans, and that would depend on the situation. So the growth of the baby, of course, we want to see how the baby is growing. The way we do it is you check the length of the long bones and also the abdominal circumference, which are the 2 good ways of finding out how the baby is growing. Also, the amniotic fluid in which the baby is present, and the blood flowing. This means how much of blood is flowing from the mother to the baby, or how much of blood flow is there. So those are good ideas to get how the growth is happening and how we can take it forward. It may be done earlier, as I said, or it may be repeated in some cases where there are medical diseases where you need to chronically evaluate or maybe check many times how the baby is doing. So multiple scans are also required in triplets and in twins. There is no way while palpating the abdomen or examining from the top can you make out that which baby is growing how much. So in twins or in triplets, we often start scans from 24 to 26 weeks. The next part of this discussion, when we move out from the imaging, is into the lab tests. So there are certain laboratory tests which we do in a pregnancy setting, and it's good to understand why they are done and for what they are done. Because often when we in our clinic, we rattle off a list of tests to be done, it's always difficult in a clinic setting to explain why each of them are done or why exactly they are done. Before we talk about the pregnancy tests, we just take a minute to discuss about the preconception tests. Now we know that there are several laboratories who have preconception test packages. So they have packages where either even it can be premarital, getting, or when you're before planning a pregnancy, they're more or less the same. So you rule out pre-existing undetected medical diseases like anemia, like hypothyroidism, like any other infectious diseases. Also, you find out the blood group, the thalassemia status, and the idea is to optimize them, which can be optimized if prior to pregnancy state, so that they are in a very good shape before they get pregnant. So the preconception tests, some of which are done also in pregnancy, would include your complete blood count, which is better than just doing a hemoglobin, a ferritin, thyroid function tests, sugar tests for the fasting blood, and also there's a lot of serology which is done blood group, as I said, HPLC is for your thalassemia and rubella IgG. So rubella is an infection which, if affects the baby, causes severe congenital anomalies in the first 3 months, especially. So and usually most of the women have got protection against rubella because they may have got this infection as a simple cough and cold sometime in their childhood or in the younger age. So that is the reason why we see that whether they have protection against rubella, and this is a test which is often done in a preconception setting, that to find out if it's protection, then they don't anything else. If they don't have this protection, we give them a vaccination. So the ideal antenatal tests initially should be prescribed at the first visit. It's usually done in the first trimester. Once you see the sonography is fine, the baby is doing reasonably well, then you have to do the tests to see that although they are all right or not. If there are abnormal tests which you find out, they will need correction. The earlier done, it's better for your pregnancy. So what are the tests which are done? Why are they done? And what to be done if they are abnormal? So complete blood count, as I suggested, instead of hemoglobin is a good idea to do. Also, we do this the thalassemia test because a significant percentage of our population have thalassemia minor, which is something which they may not have tested, but they have known to have low hemoglobin all the time. And this is something which we can really pick up by doing this test during pregnancy. Anemia by itself is very common. It's nearly 70% prevalent in the population. And oral iron tablets would be the first line. Some people have problems with having iron, but we can always mix and match and try different combinations of iron salts to find out which one suits them. So we check this very early in pregnancy. We find out a baseline, and also we check the values later in pregnancy because we understand that most of this blood loss happens during delivery. So unless you have the hemoglobin up to 11 and 12 before delivery, suddenly she will become very sick after the delivery because the hemoglobin will fall down. And then you will need to have blood transfusions and other things, which we would like to avoid if possible. Sometimes, in some cases, when a woman cannot take oral iron, we have the option of giving intravenous iron. And this is something which is very helpful because that the iron goes through the blood like a IV channel. And in that case, you do not need to take it orally. The other tests which are done, antenatals, are the 2-hour 75-gram postprandial sugar, which is better than the fasting blood sugar. So it is important to understand that 1 in 6 women in India have features of diabetes during pregnancy. So diabetes during pregnancy is something which is very common in India, especially because a lot of our women are overweight, and a lot of our women have family history of diabetes, and so they have a tendency of having diabetes, which comes out or which becomes more prominent during the pregnancy. So 1 in 6 women in India have features of diabetes, and to test that, there are several tests which can be done. But what has been standardized is that 75 grams of glucose, if you take that after a meal, maybe irrespective of fasting, and then 2 hours later, if you check a blood level of glucose, then we can have a fair idea whether this woman is going into a state where she will become diabetic or will have diabetic problems in pregnancy and needs to be looked into. So if it's not treated or we haven't checked it at all, then it will be having adverse effects on the baby. Do we have to do this PP sugar? Can't we do fasting alone? Yes, we can do, but the chance of picking up problems is much more if we do the sugar test the way which I told you. 75 grams of glucose, slowly drink it in a glass of water over 10 minutes, and 2 hours later, you get the blood tested. So repeat testing would be done again and later in pregnancy. So if the first report within 3 months is normal, we usually check around 7 months again. And if that also is normal, then we think it's all right. If it's not normal, then we keep on repeatedly checking it. The other test which we do for most women is thyroids. So thyroid function test is something which a lot of people do from the adolescent days because thyroid is very common and 1 in 9 women have a thyroid problem. So there are 2 types of thyroid problems. Most thing you would be aware. One is a hypothyroid, where it's less amount of thyroid in the body, where you need to give thyroid supplementation from outside. And the only 5 to 10% have a hyperthyroid problem, when you have more thyroid than what you need in the body, and you have to give some medicines to suppress it. So it needs correction, whichever way it is, for the optimum result. So serology testing, initially So serology test, another aspect of serology testing for infectious diseases, one more test group which we do in pregnancy, where VDRL, HIV, HBs antigen, anti-HCV, all these tests are done, and it's done routinely for all women. The other part is the blood group and RH. It is very important to stress that it is extremely important to have your blood group and RH typing done. Sometimes people do it in their childhood and often forget about it. Sometimes people do not exactly remember. But in a pregnancy, we need a printed report. So whenever we write a prescription for blood group and RH, we say that if there is an old printed report, then you don't need to do it again. If you do not have a printed report, then kindly do it again. When you're giving the blood for so many things, you give blood for this also. So if the woman is negative, then what happens? A lot of our patients have concerns that the husband is negative, woman is positive, both are negative, and different other things. But generally now the recent guidelines and recent things are, if a woman has a negative blood group, then she needs something called an anti-D injection at 28 weeks. This anti-D injection is something which will help to neutralize antibodies formed in a woman's body if the baby is positive. If the baby is positive, there's no way of checking the blood group of the baby when the baby is inside the uterus, other than putting it into risk by trying to get the blood from the baby. So what is done usually is that we give one of these injections at 7 months. After delivery, we can check the baby's blood, and then we, if needed, if it is really positive, then we give another dose of this medicine. If the woman is untreated, and if the injections are not given and the baby really turns out to be positive, then there is a chance that later in the next pregnancy serious side effects can happen and babies can get very severely sick. What about other non-routine tests? The non-routine tests may be done depending on the medical condition, and tests may also need to be repeated. So what we said was generally a standard testing done routinely for almost everybody. But if there is thyroid problems, let's say you need to repeat thyroid every 2 months at least. If there are hemoglobin is low, if she's anemic, then that needs to be repeated, of course. Even if the sugars are high, then that needs to be repeated regularly, depending on how high it is. So it may involve even capillary blood sugar, where you do the finger pricking of your to test for sugar in a glucometer, or it may be giving blood samples, fasting and PP every 2 weeks or 3 weeks. That could be, it all depends on how severe the condition is. Then there are some tests which are specific to pregnancy, like you may have blood pressure in pregnancy. Then there's some other tests which need to be done, and also you may have cholestasis where other tests need to be done. Also, one test which we didn't mention is vitamin D. Now, vitamin D is a very common test which we do in pregnancy to find out whether there is deficiency. So just two take-home messages in the end, and then I'll be handing over. Important to follow your doctor's advice. It's whatever your doctor is saying, please try to follow it. And important for you to be a part of the decision making. So once, as you have gone through, as I've gone through this presentation with you, it's important to understand that why a doctor is telling you this particular thing. Of course, it is for your good. There's no question about it. But if you know exactly how it becomes your good, then it helps you generally to help follow the advice and to get more involved in your pregnancy, in the decision making that is happening at different stages. Thank you. Thank you very much.